Good morning, everyone. Welcome to the breast section of the 2022 ARRS categorical course on tumor imaging from screening to response assessment. My name is Debbie Kopit. I'm a breast imager in the Philadelphia area, and we have a wonderful group of speakers today that will share lots of information, and hopefully you'll learn a lot and enjoy their presentations, which I know you will. My talk is on the history of screening mammography. I have no relevant financial disclosures. My only disclosure is that I am very passionate about screening mammography. The goal of this talk is to summarize the rather extensive history of mammography, to try to understand some of the basics of the randomized controlled trials, and also review the ever-present criticism of screening mammography, and then delve into some special circumstances such as younger women and high-risk screening. As we all probably know, breast cancer is the second leading cause of mortality for women. The purpose of screening, obviously, is to find cancers before they are clinically detectable. Early detection typically equates with a smaller size and therefore a better prognosis. Nonetheless, controversy exists regarding screening mammography. If we look at the 2022 SEER estimates, the estimated new cases for breast cancer will be 287,850. This is 15% of all new cancer cases. Estimated deaths in 2022 are approximately 43,250, which represents 7.1% of all cancer deaths. The 5-year relative survival is 90.6%. So I want you to stop for a minute and just think of a world without mammography and how brilliant it was for the initial investigators to do this, including the very first, who was Albert Solomon in Germany, who in 1913 got the idea that mastectomy specimens may be able to be x-rayed. So he was the very first to come up with this concept. Later in the 1920s, Walter Vogel, also in Germany, displayed the x-ray appearance of benign and malignant disease. Again, groundbreaking at the time. In 1930, Stafford Warren decided to use a tungsten screen to better illustrate breast diseases. Little side note on him, he was actually a consultant for the Manhattan Project. Then in 1938, Jacob Gershon Cohen, along with Stigler, described the appearance of breast tissue on x-rays. Again, this had not been done before, and we all heavily rely on breast density today. The studies were criticized because of some quality issues at the time, but Gershon Cohen persisted. He was a radiologist, actually, from Philadelphia, and he joined an English pathologist, Helen Ingleby, and they actually established the earliest criteria for benign and malignant disease. Gershon Cohen also, interestingly, recommended high contrast and compression. Again, compression was not something that was typically used for x-rays at the time, and x-rays were mostly being performed to look for broken bones. Then in the 1960s, Robert Egan emphasized the use of high MA and low KVP technique, and in doing so, he created more uniformity in mammography, which was very needed at the time. He also happened to create the term occult carcinoma, establishing that breast cancer actually could be found without it being clinically detectable. And again, think about it at the time, the only way breast cancers were really being diagnosed was by clinical breast examination. So this was a groundbreaking. This also led to the term screening that Gershon Cohen actually had coined years earlier. In the 1960s, Charles Gros in France, along with engineers Benz and Gabay, developed the very first dedicated mammography unit called the scenograph. This was further refined also in Philadelphia by radiologists Harold Izzard and Bernie Ostrom, who worked with DuPont to create low-dose film screen mammography in the early 1970s. There have been numerous studies that have followed that have proven the worth of screening mammography for women. The first of these studies was performed in 1963, so soon after the development of the first dedicated mammography equipment. And that was the Health Insurance Plan Study, or HIP, of Greater New York. As I said, it's the very first breast cancer screening trial. They enrolled women ages 40 to 64 years from patients who were involved in the health insurance plan. They were randomly assigned to study and control groups. The study group had screening with both mammography and clinical breast examination for 4 years. And what was seen was a 30% decrease in mortality in the study group and a 50% decrease in mortality for women in their 50s. There was, in fact, a 23% mortality reduction for women less than 50, but this lacked statistical significance because there were not enough women in their 40s. Nonetheless, it showed improvements. The success of HIP led to something called the Breast Cancer Detection Demonstration Project, or BCDDP. This occurred between 1973 and 1980. It was sponsored by the American Cancer Society as well as the National Cancer Institute. The goal was to look at the efficacy of screening mammography for women ages 35 to 74 with a median age close to 50. Goal being to detect breast cancer in its earliest stages. The evaluations used a combination of medical history, physical examination, as well as mammography. Unfortunately, unlike HIP, there was no control group. So what did they find? Well, they found 4,443 cancers. A third of them were either non-invasive, meaning DCIS, or they were invasive less than 1 centimeter. Interesting to note that none of the cancers found at the HIP trial were less than 1 centimeter. 80% of patients had negative lymph nodes. And here's the meat of it. Mammography detected 41% of cancers in women with negative physical examination compared to physical examination, which accounted for only 9% of cancers that were not seen mammographically. And again, we all know this now, but at the time this was really important. So they concluded that physical examination and mammography both found cancers, but mammography found significantly more. Then along comes the randomized controlled trials, and I'm going to go into these each separately. And I think it's really important to know about these trials so that we can continue to inform our colleagues and patients about the value of mammography. Most of these trials were performed in Europe, particularly in Sweden, but also the HIP trial was performed in the United States, and I will get into the Canadian breast screening trial in a few minutes. These were performed in the 1970s through the 1980s. Each Swedish trial used mammography alone, meaning no clinical breast examination. Dedicated mammography equipment was used. 3 of the trials used only single-view mammography to limit radiation and also to help reduce costs. So the first of the trials I'd like to talk about is the 2-county trial done in Kopparberg and Östergötland, which I'm probably not saying correctly. And they enrolled over 130,000 women aged 40 to 74 into screened and controlled groups. They found a 30% mortality reduction in the screen group. 90% of the women who complied with the first screen had a reduction in stage 2 breast cancers by 25% compared with the unscreened controls. 7 years after the study was started, they saw 31% fewer deaths in the screen groups, and that number persists today at long-term follow-up. Limitations of the 2-county trial, well, only medial lateral oblique views were done, and this has been shown to miss up to 24% of breast cancers. The interval in which they were screened also varied, so women 40 to 49 were screened every 2 years, and it has been suggested that this is not enough time to see the effect of mortality of younger women. And in fact, if you think about it, if they were screened more frequently, they were probably more. Similarly, women in their 50s were actually screened every 3 years. The critics of mammography often look to this study and point to the lack of statistical significance for women in their 40s. But it's important to note that a large number of women who died in the screen group actually refused to be screened. But again, this is what critics point to when they do criticize mammography. Mammo and Stockholm are next. Mammo enrolled approximately 42,000 women ages 45 to 69. I'm not sure how they chose the age groups, but that's what they did. Early results for women aged 45 to 50 years showed a 20% mortality reduction, but this did not reach statistical significance because of numbers again. At 10-year follow-up, though, there was a mortality reduction of 49%. Stockholm similarly randomized approximately 40,000 women, and they looked at women aged 40 to 65. The studies were performed every 2 years using only medial lateral oblique views. And this study ended early because of the fact that the two-county trial was showing such great benefits for the women who were screened. A 21% mortality reduction was seen, but again, this did not reach statistical significance. Gothenburg was next, enrolling approximately 52,000 women ages 40 to only 59. They also used only single medial lateral oblique views and found a statistically significant 40% decrease in breast cancer deaths among women aged in their 40s and a non-significant reduction of 18% for women 50 to 59. Edinburgh was obviously performed in Scotland in the last of the trials, enrolling 45,000 women ages 45 to 64. They had 2 view mammograms and an initial clinical breast examination. Then the study becomes somewhat complicated because they did a combination of clinical breast examinations and mammography versus mammography, and then they alternated it even and odd years. Anyway, there was a 20% mortality reduction, but this trial also lacked statistical significance due to its relatively small number of patients. At this point, people were beginning to accept the fact that screening mammography reduced mortality. But researchers in Canada had different ideas and started a study called the National Breast Screening Study of Canada. And this study was actually in 2 parts. It was divided into women who were in their 40s versus women who were in their 50s. The study group for women in their 40s started with clinical breast examination and subsequent annual mammography with a yearly physical examination. The control group had a physical examination first, and they were just followed up by mail to determine their health status. At 7 years, there were 38 breast cancer deaths in the study group and 28 in the control group. This was not statistically significant, but this should raise questions in our mind about the study itself and its design. 33 women who were in the screen group had positive lymph nodes, compared with 21 in the control group. Again, should raise questions. 19 women in the study group had at least 4 positive axillary lymph nodes, indicating advanced breast cancer. We now know by direct observation communication that women received the physical examinations before they had mammograms, and women with any physical findings of the breast were put into the mammography group. So that almost guarantees that you're going to have more advanced cancers. The study then also looked at women in their 50s, and they based this on the premise that HIP was actually, the results were based on clinical breast examination and not mammography, which wasn't the case. But that's why they developed this study for women in their 50s, and they designed it to compare mammography to physical examination in approximately 40,000 women. The study group had yearly mammograms and clinical breast examination. The control group had clinical breast examination only, and they concluded that mammography was really of no value in screening. Limitations of this study are numerous, including the fact that, first of all, it was not sufficiently powered, and there was no true control group, in other words, a group that wasn't screened in one way or the other. So the data really shouldn't be used to prove a benefit. The randomized process had more women with advanced breast cancers, as I mentioned, and this therefore guaranteed more cancer deaths in the screened women. And importantly, the mammography actually lacked quality. This was evaluated by several consultants who were brought on initially and who later resigned because of the lack of quality. There was also no special training for the technologists, so they were using general X-ray techs to perform mammograms, and no special training for the radiologists. They were general radiologists who were interpreting these studies. And in fact, it was determined by their own radiologists that 42% of cancers were missed at screening. A long time passed, and then digital mammography came into play. I don't know that there are many of us who even remember film screen mammography, but I'm one of them. It was FDA approved in 2000. Initially, there was some controversy with a non-significant higher detection rate. DMIS came along, and this was a prospective trial that showed that digital mammography was more accurate in pre- and perimenopausal women, women younger than the age of 50, and women with dense breasts. The Oslo II trial was a randomized controlled trial looking at this and reported significantly higher cancer detection rate in women who were screened with digital mammography versus film screen. The advantage include lower dose, less storage issues compared with film screen, the ability to be viewed by multiple viewers, so a breast surgeon could look at the images after you looked at them and interpreted them, as well as a platform for remote reading for screening, which is increasing in popularity. It also served as a platform for computer-aided detection and digital breast tomosynthesis, which Dr. Friedel will discuss following me. Briefly, digital breast tomosynthesis, or DBT, was FDA approved in 2011, so about 11 years after digital mammography was approved. Images are acquired at multiple angles, thin slices are obtained and then displayed for interpretation. There have been multiple prospective studies that have shown an increased cancer detection rate and decreased recall rate for women who undergo DBT. And currently, TMIST is a study that's going on, and it is randomized and controlled to compare digital mammography and digital breast tomosynthesis in women ages 45 to 74. There are some issues about TMIST that if you look at the Society of Breast Imaging website, you can see that there's a lot of controversy going on, but we don't have the results yet. What about the harms of mammography? And I put that in quotations, although we do acknowledge that unnecessary biopsies and the anxiety that this produces is a factor. But when women are queried, most do not consider these to be harms, and they accept the anxiety of asking to return for additional testing, and most of them end up having negative results. Some point to lead time bias, saying that screening only interrupts the natural history of breast cancer, but we know from the randomized controlled trials that's simply not true. What about this concept of overdiagnosis that I believe was first discussed in the Canadian trials? Women who are dying of another disease or being diagnosed with a cancer that doesn't spread. The overdiagnosis estimates for women aged 40 to 80 years is somewhere around 1% to 10%, and it is not currently possible to determine whether treatment or not can be avoided in patients with invasive breast cancer. Briefly, we'll look at women in their 40s. We know that sensitivity and specificity of mammography varies by age, with sensitivity, specificity, and cancer detection rate improving with increasing age. There are age-specific differences in the accuracy of mammography, and this has been a central issue in the debate over screening women less than the age of 50. In general, the critics have looked at performance of mammography in women 40 to 49 years old compared with women greater than 50 years. And this is just not a good way to look at things. And this comparison has led to the mistaken impression that performance measures are uniform in postmenopausal women, which we know they are not, and poorer in premenopausal women. There have been observational studies that have shown a 30 to 40% mortality reduction for women in their 40s. It's important to remember that the breast cancer rate for women in their 40s is almost identical to women in their 50s. It has been suggested that if we only screened high-risk women in their 40s, that we would miss up to 75% of breast cancer diagnoses. Also, there's a 16% chance of cancer spreading to lymph node for women in their 40s versus 7% for women in their 50s and 5% for women in their 60s. So this indirectly supports screening. What about high-risk women? Multiple organizations now emphasize that patients should be evaluated for their breast cancer risk by age 25 or the latest age 30 years, and this is typically done by our colleagues in primary care medicine and OBGYN. High-risk women with certain genetic mutations, of course the BRCA1 and 2 mutations, and other genetic syndromes such as Li-Fraumeni, Cowden's, and there are numerous others. It seems like it's increasing all the time. Women with a lifetime risk of 20% or more, a history of atypia or LCIS, dense breasts, a personal history of breast cancer should be screened every year starting at age 30. These are American College of Radiology recommendations, and should receive MRI as well. We know that the randomized controlled trials showed a clear mortality reduction for women in their 40s. And even the United States Preventative Task Force agrees that starting screening for women in their 40s shows the most benefit. In conclusion, mammography has an extensive and carefully studied history that I hope you can all appreciate after this talk. We know that the randomized controlled trials do have limitations, but show a clear mortality reduction for women who are screened versus those who are not. I can't think of any other screening test that has undergone such scrutiny with prospective randomized controlled trials. Furthermore, the American College of Radiology guidelines starting at age 40 with yearly mammography are supported by many more organizations than the USPSTF, and they are less complex than the USPSTF and the American Cancer Society. I think it's our responsibility to know the data, to prove to our colleagues and patients that screening women starting in their 40s works. Thank you for your time and attention. Next up is Sally Friedewald, who will be talking about digital breast tomosynthesis, unless there are any questions. There are none on the virtual platform. Okay, thank you, Sally.